So I didn't know if anybody had announcements or any type of discussion points that they would like to discuss this morning. So I'll just kind of open that up. I think Dr. Doyle mentioned maybe talking about something he wanted to discuss, but we weren't sure. We had Super Hub last week. It was a little crazy training. However, yeah, unfortunately we didn't get cases in, so I didn't know if we could just open the floor for everyone.
Well, okay, so I actually, I'm sorry that we don't have cases. I thought we had a little backlog somewhere, but I guess not. Or a stockpile. We need a stockpile of cases. But I have a case that I would like to present with Sam Giordano. You still there, Sam? Somewhere? Oh, there you are. Is that Miami Beach or where is that? And so, I was dealing with this case. Actually, the patient who is involved in this case is a few feet from me right now, doing pulmonary rehab. And I thought of you, Sam, when I was talking to him about this, because this is an oxygen case. And over the years, you have expressed access to oxygen as an interest of yours, and you've worked on it in terms of national policy. So this is approximately 60-year-old disabled coal miner with complicated pneumoconiosis who does not have portable oxygen but needs it. When he exercises, like on his 6-minute walk test, he's down into the low 80s. Gets extremely short of breath all the time with any exertion. Really, frequently gets treated for exacerbation, but the fact is that he doesn't have exacerbation. He has constant exertional dyspnea all the time, and just every month or so, he just gets desperate and asks for a cortisone shot. And depending on where he goes, here or an urgent care center, an emergency room, he's treated as exacerbations. But really, his situation is chronic exertional hypoxemia. He has a concentrator at home, and his company would supply him with small oxygen tanks, but he says they're too heavy, he can't carry them, and so he's been trying to get a portable concentrator. And his situation really reflects several kind of double-bind situations that a number of our patients and minors are in. And it's true whether they have Medicare or Black Lung. The first one you know very well about, Sam, which is that certain forms of oxygen treatment, especially liquid oxygen, are not universally available around the country. And we've never been able to get access to liquid oxygen here in my whole 40 years here. And after a while, I stopped calling and asking about it because companies just weren't going to do it. It wasn't profitable for them. And I don't totally understand that, and I think you do understand it. But another double bind for him, and this is more true for minors, is that he has federal Black Lung benefits, so this is more of a benefits issue. And I'm not sure we have any benefits experts on this call. 2 weeks from today, there will be a benefits expert on the call because we're going to be talking about performing occupational pneumoconiosis exams for state benefits here in West Virginia. And Susie Chris, who's a real expert benefits counselor here in West Virginia, will be with us on that call. But his situation is that he's been told that federal Black Lung covers his needs, but when he tries to get his federal Black Lung carrier, and it's taken me a while to understand this. Lisa, are you here? You're a benefits counselor. Are you on?
Sure, I'm here.
Okay, great. So you can speak up on this. And actually, we need you to present this too, because you know about the oxygen issue. And the person I'm talking to who's here right now is RJ. When he tries, well, first, so federal Black Lung benefits we think of as being a Department of Labor program, and it is. So in some cases, the claims manager that a minor has is a federal employee. But in many cases, federal black lung benefits are administered by private insurance companies. And in this case, there's a private insurance company called HealthSmart. And they have their hands in many lines of business. They can be Medicare Advantage carriers, they can be regular commercial insurance carriers, but they pick up some contracts to administer federal black lung claims. This person, our patient, has been trying to get federal black lung, his federal black lung carrier, HealthSmart, pay for his oxygen and to help him get portable oxygen in the form of a concentrator. And this is the third double bind that, if I believe, and some of you who know more about this can correct me, Sam or Lisa, that if you have a concentrator, a portable concentrator, a regular oxygen concentrator in your home, you can't have a portable concentrator, either or. And so if you want one, you got to give up the other. So
I don't think that's true.
Okay, good. That's a good
That's
fact.
not true.
Okay, great. So I'll let you take over in a second.
Yeah.
So he's been trying to get his carrier, which is HealthSmart, for his federal black lung benefits, to agree to pay for his oxygen, and they don't return his calls. And when he goes to the supervisor, then the supervisor gets the claim to return his call finally after days. And on his last call, he was basically told that by calling all the time, he was harassing the claims manager, and that the claims manager was going to do nothing to help him. So I guess that, I don't know if that's the third or the fourth double bind, but it has to do with interactions between claimants and claim reps, where it seems as though the claimant is sometimes in the position of being a humble petitioner or beggar, who is in a very unempowered position. That leads some of our minors to contact their senators' offices, congressmen's offices, ask for help to get what they need, and that tends to work. Only it seems like it shouldn't be such a roundabout process. And so there's the case is kind of about these policy issues, these double binds that people are in, but also there's a very practical aspect of this case, which is just to help him, even though we can't change all the policy right now, and we can't change the whole system, and we can't make all claims reps be compassionate and helpful to their probably too big panel of people they're responsible for. What we would like is help in just getting him what he needs, which I think, and actually we have our other case, Lisa, the case of JS, the guy who just stopped being a truck driver with his O2 sat, a state of highways truck driver with his O2 sats in the 70s all the time. They finally laid him off because he couldn't do his job. He also needs oxygen and has had trouble getting it paid for. So I rest my story and would welcome input from Sam or Lisa about
Well, from what I understand, when Department of Labor is going to pay for oxygen, the minor has to have a resting blood gas less than 55 PO2 millimeters of mercury and in the blood gas. And so after it's below 55, then they will pay for it. But, you know, the problem is if you have Medicare will deny it until Department of Labor denies it, and then Medicare will pay for it. So you have this bouncing back and forth. Then the question is, you know, so when the doctor writes the order for the blood gas, is it going to be with the diagnosis of J60, or is it going to be with try and let you know DOL pay for this blood gas, or is it, and is that something that's going to have to get pre-approved, which you guys may know better than me. I know I don't have to get pulmonary rehab pre-approved with DOL, so that's fabulous. But as far as, which diagnosis do you use? Do you bill it to Medicare? Do you bill it to Department of Labor? And obviously, if you're billing it to Medicare, you have to bill it as COPD or something else. Or, and if you're billing it to DOL, it has to say J60. So, but those are the rules. That's the cutoff for Department of Labor to pay for it.
Lisa, do you know any other details of this particular case, or nothing more than what I said?
Nothing more than what you said. He had mentioned that his case manager had said he was harassing her, and that's I'm happy to reach out to her and just ask, what do we need to do? I had no idea this was happening.
No,
Dan?
there's another aspect to this, which is what the back and forth with the case manager has also been about is him getting prior authorized to have an endobronchial one-way valve procedure, which a physician at a tertiary care hospital here in West Virginia in Huntington has recommended to him. So he's been trying to get that authorized, and believes that it should be authorized by CLL benefits. But so far they've been not acting on that request and kind of delaying, and that's another reason why it's been trying to get to talk to them.
Dan, this is Sam. I appreciate Lisa's comments and your comments, but I take it from a bit of a different direction here. And I think we have to go back to the very beginning, and that is, what's the order for supplemental oxygen look like for this particular patient? How precise is the order? Because I'm sure, I remember actually when I was starting out many years ago, before Medicare, believe it or not, we had the black lung benefit, which was about the only, as we called it then, inhalation therapy benefit that existed in government at the time. And again, this was before Medicare was enacted. But the original order is in many instances the limiting factor. The black lung benefit, I'm sure, has some statutory language in there along the lines of that benefit allowing for the fulfillment of physician prescriptions and orders that are legitimate and consistent with good medicine, common practice. And I'm sure that's what the intent of the order is. But if it's not precise, for instance, there's really two sides of the pancake, like we always have known. The first side is to have a part of the order that deals with the oxygenation issue for the patient. And so we have to have an order that is aimed at relieving hypoxia, regardless of whether it's at rest or while the person is active. So we get that piece of the prescription embedded in the order. Then the next element is what I would call the ergonomic factors, and that is, what kinds of devices or device would this person need in order to carry on their routine duties? And by that I mean, in your case, in the example you gave, here's a patient on a stationary oxygen system, and as Lisa correctly pointed out, you don't get it's not an either or. You got a stationary, and if you need to move around, and that's part of the physician's order. Again, it goes back to the order. If the physician has ordered that person have supplemental oxygen while they are active, and that should be embedded in the order. Because if that's in the order, then it shows that just a stationary system is half of the order. It's not the whole order. And what we get, common practice, and this goes back almost 100 years, is we order oxygen the same way as we we did in hospitals, which is uh, we order it by liters per minute. In those days, we had gaseous oxygen. We didn't have liquid. And it was either piped in a hospital or it was in cylinders. And that was it. But if we ordered 3 liters a minute, 24 hours a day, these were for inpatients. The mobility wasn't an issue for an inpatient. But it became an issue when we recognized the need to oxygenate people outside the hospital. There's many pieces missing, but to me, the most important ingredient is a comprehensive physician order, because once that order is in place by statute, whether it's the Black Lung or Medicare, the providers, those who provide services under CMS, have to fulfill the order or to refer that particular patient's needs to a vendor who can fulfill the order. And I was glad to hear that, at least for the Black Lung program, they, in their frustration, they reached around and they wrote to their members of Congress. That's exactly what they need to do to create more attention to the problem that we've got a bottleneck, and the bottleneck, the choke point, is at the dealer level. It's not at the physician level. It's not at the patient level. It's the physician writes the order, he or she sends that into the DME. They then, depending on how precise or imprecise the order is, have the wiggle room to select devices. And in my opinion, they shouldn't have that wiggle room. That to me has a direct bearing on the clinical outcome for that patient. So if I were you, Dan, I would write, in this case, I assume the patient is hypoxic, sounds like hypoxic all the time. So they would certainly have an order there with a targeted saturation to be maintained while at rest on a stationary system. And then I would also have another part of this order about when the patient is moving around. And that would include, first of all, the adequacy of the oxygenation. So there'd be a targeted saturation that would have to be maintained by that device. And if that device wasn't robust enough to satisfy that goal, then that became a trip hammer to change that device out for one that is more robust so that the patient's needs are met. But then the second part of it is the actual weight, where you get in as a physician and specify not more than, and you put in a poundage limit that you think your patient can handle. Dr. Petty, Tom Petty, always had this goal 20 years ago of having a 5-pound portable device. And we're closer to that now than we've ever been. When he first said it, I thought he was crazy, to tell you the truth, because he was so visionary, as we didn't see that happening. But with portable oxygen concentrators, that was a breakthrough. But our prescribing practices and frankly, our medical system hasn't really kept up with it within the context of supporting hypoxic patients outside the hospital. But the more precise your order, I actually had a patient, he had pulmonary fibrosis, who contacted me, and he was given the 20-pound plus e-cylinder setup that they give you for portables if it's not specified. And he had difficulty with it, as your patient did. We coached the patient. We didn't coach him, but his physician was open to suggestions. So we put in some other elements in the prescription, and it did say like not more than 8 pounds, had to maintain a saturation of, and that sort of thing. The physician signed off on that order. That was transmitted to the DME, and the DME brought an oxygen concentrator, a portable oxygen concentrator, out the next day to that patient. So it's about how much wiggle room DMEs have. And most of these people are great people, but they're going to use what's in their inventory. They're not medical people. And if the prescription, which controls the medical side of it, gives them the flexibility to choose between a 20-pound device and an 8-pound device, and they've got 20-pound devices in their inventory, but no 8-pound devices, guess what? Guess which one your patient's going to get? And they're going to be reluctant to change it out, because that would mean they may have to expand their inventory, which they may or may not be able to do. And that's why I think we have to create more pressure, not in an antagonistic sort of way, but to put pressure on the system, if you will, not on DME, but on the system, that precise orders have to be followed. And even though they are most of the time with many other diseases and treatments, they're not within the narrow context of supplemental oxygen. So I don't know, that may have been a long way to answer, just saying a very precise prescription that deals with both the clinical abilities of the device, of the system, as well as the patient's device. And actually something I've been kicking around, I'll throw this out for all of you, and if you're going to think I'm nuts, that's okay. I get to do that now that I'm retired, come up with this pie in the sky. But I think all orders for supplemental oxygen outside the hospital should be written with portability in mind. Because the last time I checked, people outside the hospital actually move around a lot. And whether they're moving around in their domiciles or they're moving around in their communities or their neighborhoods, they're moving. They're not sitting in a chair. So why is it that the typical prescription for supplemental oxygen outside the hospital deals with them as if they were just going to sit in a chair and watch QVC all day? It just doesn't happen that way. Here endeth the sermon.
Thank you so much, Sam. That was, excellent. Really appreciate your feedback. And I'm not gonna lie, sometimes late at night I watch QVC.
Me too.
I can't sleep. And then, shopping ensues and I shop late at night. It's bad. But anyhow, really appreciate you taking the time with that feedback. And I'm sure that Dr. Doyle and everyone in here, they do as well. Does anybody else have anything, or if Dr. Doyle wants to comment on that? Dr. Doyle, I can't hear you too well. I apologize.
Oh, that's weird, because I have my my earplugs and my microphone, so it might be that this computer at work is just damned in terms of the echo.
Here, I can hear you really well right now. Perfect.
All right, I'm holding this thing up to my mouth. Maybe that's the trick. So Sam, thank you very much. That was good. And can you send us a template order like you did for that physician you were talking about, who was open to suggestions with your patient or friend? Because I think I got the points: specific, also covering activity, and with a weight limit, and in that order used an 8-pound weight limit. But if you had I think it would be nice to have a template order that we could use to remind ourselves and train our students and residents.
I'll be happy to give it a stab, and I'll send it to Elizabeth, and she could sprinkle it around the group then.
Great.
I'd be happy to, absolutely. Are there any other comments or announcements anybody would like to make before we hop off here?
I would like to get Lisa Emery maybe, and perhaps, I don't know, Krista Mistel might be in on this, to give us some of the upcoming trainings that are scheduled related to black lung and the black lung clinics and COPD, if that's relevant. Because you have their thing in October, Lisa.
Yeah, that's the National Black Lung Coalition. We're meeting in October at Pipestem, just the staff. It's not like this big conference. It's just the staff of the National Black Lung Coalition. And we're trying to invite someone with, I think in particular from Health Smart, to go over benefits. It would be nice to have a Department of Labor person to come in as well, right on top of her. And then a lawyer right behind them to dispute whatever they're saying wrong about opening and reopening claims and whether you can or can't. Really, this new part of benefits counseling for me is, you know, you reach out and you want to trust what they're telling you, and then you hear something completely different, and it's really hard. It's not streamlined. I think it makes it more difficult for the minor and for the benefits counselor. And all we're trying to do is get them in the right place. So, yeah, that they're not going to write us a playbook, unfortunately. But we are getting together and trying to address some of those issues and get some of those questions answered. We're just hoping that someone from Health Smart is willing to come and help us with those things.
So Lisa, I misunderstood. I thought that was for a wider group, but you're saying it's not really all the Black Lung Clinic staff and providers. It's more for the, when you said staff, who are you referring to?
It is for, it's going to be for, you know, all of the Black Lung sites. And I'm pretty sure, if I remember correctly, it's going to be for 3 staff members to come. And then we're going to have presenters, and we, you know, really focused on what are the things we're having difficulty with, and who can we invite to help us out with that. Of course, one of them was spirometry interpretation, and that's why hopefully you'll be there with your panel of RTs to help you out.
Right.
So, but yeah, benefits it's just huge. It's ever changing, because when the laws change, the counseling changes. Were you pulling something else for me? What did you want? Did I answer that question?
I think it was trying to get out from you and anyone else who knows whether there are other important dates for training opportunities for this group that we kind of put on the calendar and have Elizabeth and Mithra help us keep in mind.
Well, we are having the state Black Lung, no, it is the National Black Lung Conference. It's going to be in Charleston, West Virginia. If I was a guessing girl, it's going to be September 22nd, 23rd, 24th in Charleston. So those are some dates to look for to come to a conference. It's an in-person conference with limited amount of people, you know, for education purposes for all of us. So that's one. That is open to the public and to the minors.
So could we maybe at our next ECHO in 2 weeks post the information about
Absolutely.
those in the chat so people can get that? That would be great.
Yeah, absolutely.
Okay, and then I'm keep trying to see some way to get you on the record here, Krista, but an issue for us in terms of pulmonary rehabilitation is we have been able so far to do remote pulmonary rehabilitation. HRSA has, under the emergency situation of the COVID-19 pandemic, has been, and Medicare have been paying for telemedicine visits, telehealth, telemedicine, televideo mainly, visits. And they gave us a whole long list of billing codes that can be used with telemedicine. One of those codes was G044, which is doing pulmonary rehabilitation remotely. And we've actually done some of that at New River and Cabot Creek. And have been trying to expand the use of in-home pulmonary rehab using a web-based app. A big issue for not only pulmonary rehab, but everything is going to be whether HRSA will continue billing for home-based, home or remote televideo, telemedicine, telehealth visits when the emergency, which we hope will be before the end of this year, or by the end of this year, whenever this emergency situation ends. Does anybody know anything about where that stands and what the prognosis is for that? And silence is a big no, and that's okay.
Dr. Doyle, I wonder if, Grace Andorni said that they have partnered with ATS. So I wonder if that's something that they'll have, because when we were finding out that that was going forward, she was the first to send us information on it. So I wonder if she'll have some information forthcoming.
Okay, we're definitely hopeful that that some reimbursable telehealth will continue beyond the end of this emergency pandemic situation, because we've discovered how much patients like it. And we've also discovered that for pulmonary rehab, there are, especially in rural areas where people have to travel long distances, having the option of in-home pulmonary rehab with a respiratory therapist coach who communicates with you by video telehealth and helps you through that is a great option to have. But right now it's all dependent on there being an emergency, and we would like it to see it become an expanded availability of care under Medicare, since it will be needed beyond this emergency, and it is needed.
Thank you so much for that. Thank you, Leanne. And thank you, Lisa, for those dates. I'll be sure to include those in the recap, even though I know there's more information to come, but I'll, just to have that on your radar and everybody else was unable to attend today. Is there anything else before we call it and give you 20 minutes back? All right. So I only have one announcement. Next time we'll meet will be August 2nd, and Dr. Doyle will be presenting on clinical and legal pneumoconiosis. I can't say that well, sorry. Clinical exams related in West Virginia. All right, thank you everyone. I hope you have a wonderful rest of your day.
Thank you.